Today we are showing you a new procedure with Dr. Pan from Beijing that is about a bioresorbable device to close the PFO. With me is Kolja as well, and Judith doing the echo, Dr. Wissing anesthesia, and 25 people in the room. And let me show you the slide presentation of the case history, please. That is a 56-year-old female patient. She had old cerebellar infarctions detected on a CT scan without other potential causes beside a PFO. She also is suffering from nickel allergy, which is the indication why we use one of the indications why we use a bioresorbable device in this patient. EKG normal, Holter normal. I mentioned the findings on CT, MRI, carotid duplex normal, transthoracic echo normal, and next slide please shows you the TEE. It's a pretty large PFO with septum aneurysm and a big gap between the septum primum and septum secundum. And next slide, please. This is a slide of the device we're going to use, the Memosorb PFO device, which is made of PDO and PLA. So the entire device is completely resorbable and will become finally carbon dioxide and water. So this is a very nice concept. Maybe Dr. Pan can explain a little bit more about the device.
Yeah, thank you, Dr. Haas. So, dear colleagues, I'd like to show you the occluder. Because the absorbable material, the elastic of the absorbable material is poorer than the mental occluder, so you can see when we advance the whole occluder out of the delivery system, the occluder cannot recover to double disc by itself. So we design a locker inside. That's the special thing. We pull the line, and the occluder will recover to double disc. And here is a locker inside. The locker is very simple. It's a knock. When you put the knock out, you can find the knock. Yeah. When you put it out, it cannot retract back by itself. So the occluder is locked, and the double disc straight is stable. Thank you.
So this device does not have any metal, which means it's not visible on fluoro. So that means it does not make sense to use fluoro at all. That means everything is done under echo guidance. We are standing here without any leads. And so this is also a new experience, because when I came into the room, I started the X-ray machine, and then I realized, oh, we don't need that. So
quick
we are
question,
ready to start now. Any questions so far?
Quick question. How do you know she's got nickel allergy?
She told us, and we did a test.
Oh, okay.
We didn't want to test this with the device, so we know this in advance.
Okay.
Right. Horst, can I ask a question?
Okay.
Iqbal Malik. So the nickel allergy question, I'm over here, Shek. So the nickel allergy question, I must say I've never asked the question and I've never done the test. Do you routinely ask the question and do the test, and do you believe the test?
Well, actually, the history of these patients is pretty clear. We know from other implants that there are side effects. There may be also side effects with implanted devices in the hip area, in the hip replacement, in dental medicine. So it's known that there are side effects. And actually, and that's something I learned only recently, when you go into the IFU of all the currently available devices, they are actually contraindicated. So if something happens, there have been reports in the literature where the device has to be removed and then the allergy symptoms disappeared. So I'm taking this more seriously now, also because we have alternatives. But yes, it can be done. You can implant these devices, but you never know. If these patients later on get some eczema, you don't know whether it's related to the device or not. And most often we say, oh, it's not related, but we don't know. We just ignored it over the last 20 years.
Quick show of hands in the audience. If you ask nickel allergy question before implantation as routine, raise your hands.
Nobody is raising his
Small
hands because we are
percentage.
ignoring it. I know.
It's about small percentage.
It's about 10% of people.
Yeah.
And by the way, if you do the
I know.
tests systematically, 20% of the people will test positive.
Okay.
So that's an interesting number to keep in mind. And people are developing new alloys that are specifically nickel-free.
I think one more point I'll make, Iqbal again, is that skin allergy to nickel, I think, is different from a systemic reaction. And I think that's the problem with doing skin allergy, because then certainly in my practice, 20% of my patients are not coming back with funny symptoms. There is the occasional one, and I agree, Horst, there's a case reports of occasional devices pulled out. So I get it. If the patient declares a nickel allergy, then there's a difficulty, but I'm not asking for trouble, and therefore I definitely don't ask.
So those people who didn't put their hands up, are there any patients that have had nickel problem afterwards and have had to remove the device? If you could show your hands. So I can't see who that is. If you could just expand on what you did and why and what happened.
Yeah, so Mark Reisman. So we had a patient who initially said she did not have a nickel allergy and did wind up having a significant reaction after the device was placed. Severe headaches, very, very sort of difficult symptoms to put together, but she did have the device removed ultimately and then recovered. She had no further problems. So we ask all the patients if they have a nickel allergy.
Okay. All right. Horst, oh yeah, go ahead. Seibel, I think it is. If you can move near the microphone somehow.
I will also comment that you're correct that the relationship between systemic and skin is unclear, and that we've actually taped the device on someone's skin occasionally when we do this, and we'll see reaction. We can't figure out sometimes if it's due to the tape or the device. Really tricky, very, very difficult to systematically have a plan for.
Difficult area. Seibel, go ahead.
So the patient that I'm referring to was actually a patient that I didn't do, but my colleague did. It was a 56-year-old nurse. She clearly had symptoms of chest pain, all allergic coughing, and all sorts of weird symptoms. Ultimately, he went to another hospital and took it out, and they said it was inflamed. She actually filed a lawsuit. So, I mean, these things can be very tricky. I mean, so it is sometimes and she did say that she had told the physician that she had nickel allergy, and the way she said it, she had allergies to her ornaments. Right. So earrings and things like that.
Yeah, and it's usually not the kind of allergy we just get from earrings or rings. These are really very significant allergies to nickel.
Okay. All right, Horst, some interesting discussion, so carry on now.
So Horst, I have a question. Do you consider doing a noble stitch in this patient? Because that's the other alternative.
Yes, yes, that was actually the initial intention. But when you look at the morphology, and it's just not a good case for that, because there is some overlap, but it's not really a good tunnel. I'm not saying that it's impossible, but the success rate in that morphology is even lower than in regular cases with the suture-based system. Usually the success rate is about 80%, but in that morphology, I think it's less than 50%. Most of these patients then have a residual shunt. So she's just not a good candidate for that.
Okay. So Horst, let's move you on now. You don't need to do fluoro, as you said. So it shows the echo.
Yeah, okay. So actually, in order to cross the septum in these procedures, Dr. Pan has developed a special wire which makes, would you like to explain it?
You shouldn't explain?
Because that is the difficulty when you not use fluoro to see the tip of the wire.
Yeah, so they've developed this. It's tipped with a rhombus-shaped device, essentially, which makes it much easier to see under echo. So it enables you to position it precisely in order to not perforate anywhere. And can you push it out a little bit? Yeah. Also, the tip is fairly flexible, so if it does touch any tissue, then it does not cause a lot of force in order to avoid perforation again. You know?
Yeah,
Can you pull it back?
Yeah.
So okay.
Okay.
So does that wire have nickel in it?
Horst?
Probably yes. Probably yes.
Oh,
But,
Jan,
I mean,
If it has
it's not a
nitinol, it has
problem.
nickel. Yes. Yes.
Yeah, probably yes. Yeah.
but it's not there for long.
But we are not concerned about any acute symptoms here. We are concerned about long-term effects.
Yeah. Okay, so tell us what you're doing now, either Collier or...
So now, Judith will now show us the abdominal ultrasound so we can see how the wire and the catheter are passing the IVC.
Push it out? Okay.
Horst, is it strange for you to do a procedure without fluoro?
Absolutely. As I mentioned, it's absolutely crazy. Absolutely crazy.
You should do more of it, though.
Something very odd about it.
Yeah.
More echo, less fluoro.
Here it is.
Yeah.
And there you can see it.
Yep.
So now we're opening the device on the wire.
Which number?
Or we can go to, should we go now to
DTE.
transesophageal? Or we can go, just go across, yeah.
So Horst, I presume the femoral access was ultrasound guided puncture in any case, was it?
Yeah.
And here you can see it.
Yeah, everybody, you can see the top of the wire. Yeah, and this is the direction advance, the whole system advance, advance and rotation a little. Rotation more. Yeah,
There it is.
I pull back the top, and yeah, rotation and past. Go ahead. Yeah, past. Okay, good. We have passing. Pass. I open the caster. Yeah, now you can find the top of the wire is located in the left atrium.
Can we see the pulmonary vein?
Yeah, can you see the pulmonary vein?
We want to avoid the left atrial appendage.
25 degree maybe is better. Yeah, good. So you can find the top of the wire is in orifice of the pulmonary vein. It's okay.
Yeah.
You don't need to insert it. Okay. We measure how deep we have insert. No. Mark here. Mark here.
Yeah.
This hand mark here. This hand mark here. Yeah. And go with me. Go with me. Yeah. Hold it. Yeah. Go with me. Good.
Now we
Hold the
can
wire
measure.
and we measure again. Yeah. How deep you have insert. That's good. Yeah. Okay. Hold the wire.
So what are you measuring now, just to expand?
Be careful. Be careful. The top of the
Oh, the
yeah.
distance
Advance the wire a little. Advance the wire a little. Yeah. Good.
to know the distance of the groin to the heart.
Right.
Yep, have it.
With the help of the caster. Okay, I take it. So we know how deep we have insert your wire or the delivery system.
Jacques, did someone answer your question? I didn't. We're measuring it so that we know how far we're advancing the sheath for the device.
Right.
It's 65 in Europeans.
Can I ask another
55
question?
in Chinese.
Is the
Delivery system is 14 French, and the diameter of the occluder is 34.
Yeah. So, Iqbal,
So
I think you
a
were
question-
Can
a
also see
question.
the tip of the
Is there
sheath
enough,
under echo, but sometimes if you are in the wrong way, then you want to make sure that you're not inserting something too deep into the body.
Yeah.
How are you doing
Wires to the
device sizing for this device?
Rotation your plot to find the wire. Yeah, you can find
Actually,
the
we
wire, right?
picked the larger size. It comes in different sizes, I think. How big is this device?
Yeah, I mean,
Yeah, they can find the wire.
3418, wasn't
Dr.
one
Pan,
of
what
this?
You could always
the-
balloon
the
size on
diameter
this
of
wire.
the device you're going to use?
Yeah, just the wire. No problem. Yeah.
Still in the left.
Yeah. If you lost the wire, you can pull back a little and let echo to find the top of the wire. Okay. How to mark by yourself. Good. Go
But
ahead.
Iqbal, if they wanted to balloon size, they'd have to put leads on, and they're already scrubbed.
But why would you do that? Because
Hello, Sandy.
if
You
you've
can
got
do it-
Bushra in the room, she can measure on
Haven't
echo
passed.
the
You
balloon
can
size.
do it under echo, yeah.
Because the
Could
top
do a
of
balloon
the
sizing, yeah.
because the top of the wire cannot be retract to the inner core. You can feel we cannot retract it to the inner core. So now it's easy to find us to make sure where is the top of the wire, also the top of the delivery system. And then we put back.
Sorry, can we explain that? Because you said the wire is locked in some way. How is it locked?
Okay?
Well, it's difficult or impossible, I don't know, difficult to pull back the wire into the catheter, into the dilator of the sheath.
Get it out.
it requires a 6 French catheter to put it through.
Yeah.
So the dilator, of course, won't work.
But that's intentionally. So now they pull back everything, the dilator and the wire, as soon as they are sure that they are across the defect.
So, Horst, as far as the device selection is concerned, how,
Yeah.
one of the questions asked was, how did you select the device for this PFO?
Well, initially we had prepared a 24 millimeter device, but then we saw again the anatomy and exchanged it for a bigger one. So, Dr. Pan, what is the size of the device we are going to use?
Size of 34.
34, okay.
Yeah.
That is the maximum diameter.
But what made you change to 34?
The floppy septum and the big hole.
Because the septum is too short. So we want to use a big one to cover all the short region when the occluder is absorbable and replaced by the endogealizations. So the patient will have a stronger septum.
Point I was trying to work out in my head is
inside.
Floppy septum fine, but how do you then select the 34 device?
We just measure the diameter of the short air. So we hope the occluder cover all the short region. Okay?
I'm not sure, but...
Any value in doing 3D echo and measuring the left atrial mouth to make sure that that mouth is not very wide and is fully covered by the device?
You see it.
Oh, there you are.
It's quite broad, which is probably one of the problems with Noble Stitch, that you cannot close it up through the whole width of it. And, well, you see it's actually almost 15 by almost 6 millimeters. And the floppy part of the septum was about 23 millimeters long. Let me see where we have it. There you go. And this is the aneurysm. And during the setup with the anesthesia, I caught a good moment to prove that this is a relevant one.
I think it's
propofol, a little bit of propofol.
I think it's important to recognize, though, that measuring directly in a 3D image can be a fraud, and you have to use multiplanar imaging to really align the planes so that you're accurately measuring. Or you use a cropping plane that's plane and reduces the 3D to a 2D to really get accurate measurements. And then 3D color may be quite helpful. And you can cinch down your 3D color, you sustain frame rate in order to get a good measurement.
Yeah.
So we saw the disc a little bit, or briefly.
Let's focus on the sheath. You want to see the device when it goes through.
We just saw part of the device. I don't know if you saw this. Can we see the tip of the...
Tip of the sheath?
You're very close to the aorta here.
Yeah.
There you go.
So now,
that's better.
The first disc, okay? And we put the line, get the first disc shape to disc, okay? And put back the whole system close to the septum. Good, okay? And we release the other side, hold the cable. Yeah, hold the cable, right, good job. Okay, and advance. Okay, and we put the line, okay, right,
very nice.
In the right position. So now we get the occluder reform to the double disc shape, and we cover all the short air. Now we haven't locked. We just test whether the occluder is in the right position.
So at this point, Jiangbin, you pulled the strings but is the device locked or retrievable still?
It's not locked yet, so it's still retrievable. And we can lock it and then test whether it's locked as well. So Dr. Pan just explained this to us. When it's locked, both of the sides, when we do a tuck test, will move, whereas when it's not locked, only the right atrial side will move.
Yeah.
To show that, can we do a tuck test now?
Yeah, sure. It haven't locked. So when you pull the cable,
So now I'm pulling,
yeah,
and only the right atrial side is moving.
yeah.
Left atrial side is stable.
Yep.
Okay. So are we ready to lock now?
Can you put color on,
Echo
color
filter
compare?
is
Take a look.
Okay.
Judith, you're happy?
Yeah, I'm happy.
Yeah. Before we lock, we advance the sheet. Get the sheet to touch, okay, to provide support. And then, yeah, one hand, you try.
Hold that one.
Dr. Hoss, can you help
Is
to,
it this?
yeah, make the, yeah, this one, this hand here, this hand, yeah, okay, good. Pull.
I felt it.
Yeah.
Could you feel it as
Feel
well?
it here yet? No.
I felt it on the sheath.
Okay, don't worry, we can test. We can test.
So now
So
we'll do a
it's
talk
locked.
test with locked, and you
Oh,
can
it's
see
locked, yeah.
none
Yeah.
of the sides
It
are
move
moving. The
together.
whole device is moving.
Yeah, it move together. Okay. Good.
So, Horst, you were feeling what on the sheath? The locking or what?
The click.
The click.
The locking. Yeah, actually, I could feel the locking on the sheath here.
Yeah, it move together. Okay, keep the knife.
I'm more sensitive than the younger generation.
Yeah,
you know?
yeah.
You are more sensitive.
Yeah, Dr. Pan, just wonder, is there any radio opaque marker on the device? And
No.
No, that's why we don't do fluoro.
yeah, and then what if
And
the
we
device
take the
embolized?
light out or the patient.
Well, these devices don't embolize, but if, then we have to find them by echo, right?
Or you can delete this one. Counterclock.
Very important technical
Are we
question there.
releasing the device?
Yeah, we are really.
What point do you evaluate more by color to see whether this is a full closure? Is it before lock? Is it after lock? Is it after release? When is the best
We
time?
never use color in PFOs. We never use color in PFOs.
Yeah, it's unlocked.
So, Collier, you release. Oh, you
No, it's
released it
unlocked.
now.
So
Yeah.
it's unlocked.
Yeah,
It's released,
Yeah.
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 10 minutes,
Check.
15
This is Nick speaking to your left in the back.
Okay.
This is a big bulky device, and when it gets absorbed, how are you sure that tiny little pieces don't fly around in the body and get embolized?
Okay, good question.
Well, Dr. Pan, would you like to answer that? So how can we be sure that not small pieces of the device are embolizing and going to the body?
Yeah. So in the clinical trial, we have tested more than 200 patients. We screen, we perform CT for the patient, and an animal test. We also test whether they have any embolism in liver or other organs. There is no problem for this occluder. And the material is approved by FDA, so we only use PDO and PLA is safe.
And how, what is the total experience now with this device? How many patients have been treated in total?
In total now is almost more than 2,000 cases. We have finished the implantation.
And what's the timeline?
And how long
Almost
is
1
it take to device to be absorbed?
1 year.
1 year, sorry, 1 year.
And then, what about the question GT raised, Giko, about embolization? If the device embolizes, how do you retrieve it, or what do you?
You mean that? I think your question should must be if the occluder go away, how can we find it, right?
Yeah, correct.
Yeah, right. Because there is no marker, so it's not easy to find it actually. But we also can find, because for ASD or PFO occluder is very big. It cannot pass the aortic valve or pulmonary valve and go away along the artery. So it's easy to use echo to find it. Most of the occluder should located in the heart. And another thing is that if it's the VSD occluder, it go away, it's smaller, it can flow along the blood to the far away. So we can use fluoroscopy and perform angiography to find it.
Because there are
So
occasional.
did this happen to your head?
No.
No.
No,
Okay.
but in animal test, we have test.
Okay.
There are occasional either ASD or other device, PFO devices that embolize to the ascending aorta, descending aorta, and it's really if they go that far, how you find them.
What happens? I mean, after 1 year when it's absorbed, what happens to the PFO itself? I mean, does it there is scar tissue remaining? Does it reopen? What's the long term after absorption look like?
Right, Jiangbin?
Okay.
So the question is,
what happens once the device is absorbed? What happens in the region or area of the PFO?
Yeah. So in our clinical trial, we submit the paper. So in the 2 years follow-up, we now have the similar complication just like embolization. And the question focus on after the occluder is absorbed, what replace? Is there endogealization? And we also have some fiber to replace the occluder. For ASD, absorbable occluder, you can find, now you can see the occluder is stiff, it don't move, which the heartbeat. But 1 year later, the segment move, which the heartbeat is replaced by the endogealization. It's not the material because it can move, which the heart.
Have you seen cases of calcification in the area where the device has been implanted? Because that has been reported from other bioresorbable devices. There's no calcification, also not in animals? Okay.
Yeah. Matt?
Yeah, Shaq, it's going to be a cheeky question from me. It's a bioabsorbable device, so how do you know if the device has been bioabsorbed or if it's been embolized? Because you can interpret the absence of material as both events, right? You'd never find it. But the serious question was going to be the mechanical property of the device. It was very soft as it came out of the catheter quite slowly. And some of the times when we use these Amplatzer-type devices, they come out of the catheter like a bullet out of a gun. But you have to have some control over the cable. And particularly for the left atrial appendage, which is really thin and fragile in older patients, something that was a bit softer coming out of the catheter might be safer, perhaps. How could this technology be adapted for an appendage? Is that possible? Could you put anchors on it?
You mean the appendage occluder,
yeah.
Right? So now we are carrying out the clinical trial for absorbable appendage occluder. We have recruited more than 50 patients. So we also have the similar designs to get the occluder stable in the appendage. And because the first patient is almost 9 months, so now the follow-up is good. So we also hope that we can finish the trial and report the data from the real world to you.
But back to your question, Matt.
All right.
You'd still see changes in the septum. So if it embolized and it wasn't endothelialized, you'd still see it on the under echo.
Yeah.
Shaq, can I ask a question?
Yeah.
My question is regarding embolization. The problem is, even if you are able to see the device or locate the device, once the device is locked, it cannot be slenderized. So I think embolization with this device amounts to surgery, in my opinion, and I could be corrected if I'm wrong.
Yeah. So Zhang Bin, did you get that question from Barrett?
Yeah, so mean that if the occluder go away and it's locked, you cannot use catheter to take it out. Yeah, you are right. For most of the patients, actually we don't have this case. So if you really have the occluder go away and it's locked, I think the open heart surgery and to take it out is reasonable. But another idea is that we can use a bigger sheet because the elastic of the absorbable material is poor, very poor than the mental occluder. Maybe we can catch and put it in a larger delivery sheet. Maybe, but we haven't tried this.
But if you can't see it...
I also don't want to try.
Yeah, if you can't see it, it's difficult to work out whether you've caught the attachment point or the side of the disc, and how do you
we can see it on echo. We can, Chuck, we can find it under echo. We can evaluate all vessels by echo.
In the descending thoracic aorta?
Yeah, sure, we can.
Okay.
By TE. And in the abdominal, we can do it from external.
Okay.
In the iliacs, also from external, so we can go everywhere.
The aortic.
Okay. Horst, Zhang Bin, Kolya.
Shaq, may I ask a simple clinical question?
Yeah, last question then, because we're way behind.
What is the long-term antiplatelet strategy with this device? Once it's endothelialized, do you discontinue or?
Right, Zhang Bin or?
So long-term aspirin or clopidogrel?
Yeah. Aspirin only for 6 months. Only for 6 months.
Okay.
6 months is okay because the endothelialization is similar to the mental occluder.
And then stop altogether, yeah?
Yeah.
Okay. And then do you do bubble studies at the end of this procedure or not?
No, we never do it after PFO closure because even with devices, there's always a shunt. If you have good contrast, so we have stopped doing any bubble testing after device closure.
All right. Great case. Thank you very much. Well done to the whole team.
Thank you.